everybody. I'm going to do this wrap-up video a little bit different format, not in front of my whiteboard because I cannot reinvent this pretty dermatome map. I think it's important for spinal cord injuries to understand and really get to know the dermatome map. So, because wherever the level of injury is, that level and above is where they're going to have deficits and problems. So let's start from here. And let's go back to the beginning. So if somebody has a spinal cord injury, it was most likely from an accident. And something called spinal shock can happen. So if you are in a motor vehicle accident and develop a spinal cord injury or any type of accident, your body can go into spinal shock. So it's a temporary syndrome, temporary neurologic, so you don't have good reflexes, you can't feel anything. So there's been many times where patients will be like, I can't feel my legs, but then end up having a full recovery. It was just because you had a spinal cord injury, but it was more like a spinal shock, so it was temporary. These people, their blood pressure is going to be low and their heart rate's going to be low if they experience spinal shock. So don't get that confused with autonomic dysreflexia or hyperreflexia. That's a totally different issue, and your blood pressure and heart rate are going to be up with that. Okay, so let's talk about different spinal cord injuries. And also, going back, you want to always immobilize, no matter what. If you have no idea what kind of injury they have, you always want to immobilize. So I'm sure you guys know that by now, but just make sure you have that drilled in your brain that we always immobilize because we don't want to re-injure and we don't want to aggravate the injury that's already there or cause more injury to it. So, okay. So there's complete cord involvement, incomplete cord involvement. There's all different types of spinal cord injuries. So let's just make it easy. The complete cord involvement is, let's just say you have an injury at T4, it's completely severed through. So you are going to have complete loss of function, motor function, sensory function, the whole works to anything below this level of T4. So that will be everything from here down. But if you have an incomplete cord injury, maybe it wasn't severed all the way through at this level. So you may have some sensation. You may have a little bit of feeling in some area on your body below this level. So it's incomplete. So it just depends what part of the spinal area at the T3 level that was cut through. Or that was injured. So it's mixed. So some of the nerve tracts will still be able to work. All right, so that's incomplete versus complete. We just don't know, until probably like 48 to 72 hours after injury if they are going to recover from that or not, or if they do have a complete versus incomplete. You can have a good idea, but you can't really completely tell until after, the injury and after they're stabilized and they start, vitals start stabilizing and swelling starts going down, which brings me to secondary injuries. So there's the primary injury from the motor vehicle accident, okay? But remember, it can increase to a secondary injury. That just means that if you have any injury, even if you, let's say, cut your hand, might get swelling, you might get redness. But if you have that in the spinal cord, it's your body's response to try to heal the area. So you're going to have inflammation, it's going to swell, and you can have increased bleeding. So that can actually progress to more of a complete spinal cord injury from an incomplete spinal cord injury because it ends up damaging the rest of the cord. Okay. So I want to go over a couple scenarios, and then I'll go over the other types like Brown-Séquard, cauda and central cord syndrome in just a minute. So let's just say, for example, we have a C4 injury. So let's see, we have C4 is here. Now this is the back of the body, and this is the front of the body. I hope you can see my cursor here, but the right is the back of the body. So we have a C4 injury. So what kind of issues, let's say it's a complete cord injury, and so they don't have any feeling below this level of C4. And if so, we have C5 here, we have C6, C5, C6, C7, C8. So there's no feeling, sensory loss, motor loss, the whole works, and all the way down. So all of these are affected. So what's going to be the main thing or the main priority for this patient? Look, all the respiratory muscles are going to be affected. So they are going to have loss of respiratory function. So anything that's C4 usually and above, they have respiratory issues. So these people probably need to be on a ventilator. And we have seen that. What was that guy's name? Oh my gosh, this is kind of my generation too. Oh boy, Reeves. His last name was Reeves. But anyways, he had a horse. He fell off a horse, and so he ended up having an injury that required a vent all the time. Okay, so let's talk about, and so if you have a complete cord injury, you can't detect any pain or anything like that. Nothing, no tenderness, no pain, which will bring me to autonomic dysreflexia in a minute. All right, let's say we have a T3 injury. So let's go to T3 here. All right, so T3. So looks like, though, they will be able to move their arms, right? Because we're at T3 and all these are above that. So they should be able to move their arms at a T3 injury. They should be able to breathe too. So because remember, the lungs are really here. Now, they may have problems with coughing, cough reflex. So they will probably need some help with that. But they can move their arms and they can breathe. Let's go for an example and do a C8 injury. So let's see, C6. So we have C8 right here. We also, yeah, we have C8 right there. And then we start with T1 right here. So T1, T2. So these people, they also can breathe, but they can have problems again bringing up secretions. All right. Anything C4 and above, they cannot breathe at all. But if you start going down, they probably can breathe, but they're not able to bring secretions up very well. So that is where a long recovery comes in, and try to teach the patient how to breathe correctly. But these people with a C8 injury, it looks like they're not affected up here uh, in the facial area, so they can probably eat, they can probably swallow, etc. Okay, so let's talk about cauda equina. Anything down in the sacral area, and this would say if you have a lower back injury that affects the nerves there, cauda equina means that you have loss of control of bowel and bladder habits. And that's just not a good thing to have, and that's an emergency. So anybody that comes to see me with low back pain, I always, ask them if they have loss of bowel or bladder habits, because there are some people that have had an injury, say a year ago, and then re-injure it again, and then progressively have cord involvement and then they come in to see me and they're like, oh, I have numbness down my right leg now, it's tingling, and so I want to make sure those sacral nerve roots are not affected. So I always ask them that. But that's cauda equina. So it's areflexic bowel and bladder. It's the distal cord and nerve roots. So they're going to have, whoops, what happened? Lower extremity paralysis from here, because it's going to be affecting most likely L1, L2, but involving S4, S5, etc. The Brown-Séquard syndrome is where we can get a little confused with it. So one side of the body has no motor function, no position sense, so they can't tell like where their arm is at or where their leg is at, and they can't feel any vibration, no vibratory sense. Okay, so that's one side, but the other side um, has motor function, okay, and they can feel that, oh, my arm's right here, but yet they can't feel pain and they can't feel temperature. So it's a type of incomplete cord syndrome, but it's called Brown-Séquard, where it's very specific, where you don't have the motor function and you can't tell where your arm is or leg is on the one side, versus the other, you can, but yet you can't feel pain on that side or any temperature feeling. So don't forget about polyothermic. I probably didn't pronounce it correctly, but they're not able to recognize temperature changes. So for teaching and nursing interventions, we have to make sure that the room is not too hot, not too cold. We don't want to cause any issues with temperature. Central cord syndrome, their upper extremities have an increased impairment versus the lower extremities. So again, it's another incomplete cord injury. So they can't move their arms at all, but perhaps may be able to move their legs a little bit. Well, that's the difference. That's central cord system. So how are you going to check to see? So let's say this patient's in ICU now at a spinal cord injury. Let's just say at T10 area. So they probably are having paralysis down this area, loss of motor function, depending if it's the complete or incomplete. But how are you going to check to see if they have any feelings? So you're going to check for sensation, right? So you're going to know, you need to know where these dermatomes are. So for example, when I worked in recovery room, patients with epidurals, I would have to check their sensation, and I'd start down the line and do different spots. You don't want to tell them where you're poking because then it's psychological. Then they're going to may psychologically feel that in the area that you told them. So you don't want to tell them. You want to tell them to close their eyes. You don't want to just poke really hard first. It's always light touch. And you want to do an irregular pattern, because if it's regular, they're going to know you're going to go to the next level, down, down, down. So if you had an epidural and you're checking, eventually they're going to start feeling starting up here, and then it's going to progress where they can eventually feel down here at their toes. So I can tell, when the epidural's wearing off versus where it's not. But then I can document, okay, they're at L2 now, or they don't have any sensation yet. I think an epidural is a good example of checking for dermatomes. But just make sure when you're checking them, it needs to be irregular. They're supposed to, not be looking, and you want to do light touch first and do an irregular pattern. Okay, these people also, if they have a spinal cord injury, again, nursing care comes in. How are you going to treat these people? They're in ICU, they're on the floor, they're chronic. You get them on the floor for, let's just say, a cellulitis or something that's irrelevant, but they have a spinal cord injury. These people that have cervical spine injuries, or even in the thoracic spine injuries, are immobile in the lower extremities. So again, now we start thinking pressure sores, repositioning. These people need to be repositioned every couple of hours, because we don't want them to develop pressure sores, because these people have lowered immune systems anyways, and once you get a pressure sore, it's really hard to heal. So make sure that you keep that in mind. Also, autonomic hyperreflexia. So the best way I can describe it is you can't feel anything, let's say, below your mid-waist. No, let's just say your lower thoracic area. All right, I'll use an injury. We have a T8 injury right here. They can't feel anything here. So let's say it's the middle of the night and you wake up and your bladder's full. And you can feel your bladder, and you're like, oh my gosh, I gotta get up and go. It's like, I really gotta go, right? You can feel that, and it's uncomfortable, correct? So what if you didn't feel that? You wouldn't know you had a full bladder like that. And Imagine that going hours and hours. What is going to happen to your body? What's going to happen is that you're going to develop more of an autonomic hyperreflexia. So your autonomic nervous system is going to kick in and go on overdrive basically because it's saying something is wrong. We have this full bladder here. This patient can't feel it. You start sweating. You start having a high blood pressure, increased anxiety. You don't feel well. And you're like, don't know why you don't feel well because you have no motor function down here. So the first thing that you would do is there's a, hold on. Okay, so you need to take care, you need to put the head of the bed up 45 degrees, make sure the patient's sitting up. You want to determine the cause. Most commonly, it's bladder issues. Sometimes it can be bowel issues or pain from something else, but it's very commonly it's because their bladder's overly full. And so you want to check that. And you want to call the healthcare provider. Um, that would be the next thing. And then you want to treat according to what the physician tells you to do. There's some people that do intermittent caths, but let's just say they're in inpatient because they're sick and they're not able to do their intermittent cathing and it hasn't been done in hours. Let's just say, you never know what can happen, right? And then they develop symptoms of autonomic hyperreflexia. So I think I found a good video, so I was going to post that for you. All right, and then a couple other things since I'm on this. Let's just see here. Guillain-Barré is loss of motor function too, and it's progressive. It usually happens over a few days. And when I think of that, I think of a common reason is because they've had a viral infection and then they develop an autoimmune response. And so they develop this Guillain-Barré. So it can be fatal for sure, especially if it affects the respiratory muscles. But on the other side, many people recover from it. And sometimes you just have a little bit of uh, neuropathy symptoms all the way up to complete paralysis and you can't breathe. So it's just different for everybody. Usually, people are on high doses of prednisone during that time. But worst case scenario, they need to be on a ventilator until their system decides to recover. And again, that's given with steroids and other treatments, but it is a serious thing. And there's some talk that it's from the flu shot. Now, it's very, very rare, but it is a reaction to the flu vaccine. Although very rare, you have more likelihood of getting the flu than you are getting Guillain-Barré from that. All right, and that's it on this section.